Okay, good evening, everyone. Welcome to this information evening. And the topic tonight is making modern families, donors, recipients, and surrogacy. I'm Dr Sarah Wakeman. I'm the Medical Director of our Christchurch Fertility Associates Clinic, and I'm a obstetrician and gynaecologist, as well as a specialist in reproductive endocrinology and infertility. So what we're going to cover is just very briefly the law, treatment options that are available for these situations, what's involved with becoming a donor, what's involved when you're a recipient, receiving donated eggs or sperm, a little bit about surrogacy, a little bit about the ethics committee process that surrogacy applications and some other applications have to go to, some information about costs and funding, and then time at the end for questions. So if you have any questions, please, just type them in as we go along. And I have Kelly in the background who will be making sure that those are easy for me to see at the end. No one's going to be able to see any of your identifying information or anything like that, and I'm certainly not going to use people's names about who asked a question, so feel very free to ask questions. So firstly, the law. All of fertility treatment, all the fertility treatment we do all of the time is governed by a law called the HART Act, the Human Assisted Reproductive Technology Act, that came in 2004, and alongside it is another piece of law called the HART Order. And basically they state what treatments clinics can do as established procedures, and that's all our usual insemination and IVF treatment. But they also make clear which things are considered, which aren't considered established procedures and need to go to the ethics committee for some further oversight, basically. So they're things that are considered more risky. It says that donors and surrogates need to be altruistic. So the wording in the law is no valuable consideration. So that means people can't be paid a large sum of money to donate eggs or sperm or to be a surrogate. So they're not doing it for the money. It also makes it very clear that children have the right to know their donor's identity. That is, clearly in the HART Order. All of our what we call clinic donors, who are people who come forward to the clinic offering to donate but not offering to donate to a specific person at that point, they're all aware that they need to be identifiable in the future. And recipients are made aware of the importance of telling children their donor conceived. And in fact, more recently we've made a policy at Fertility Associates that if we have people wanting to use donated sperm or eggs who say they wouldn't tell a child that they were donor conceived, then we won't allow them to use one of our clinic donors for their treatment. And the whole idea, the whole thing behind this law is that it's aiming to protect donors, recipients, and especially children, because the children aren't born yet and don't have a voice at the time decisions are made. So treatment options that are available in this area are, if people are using donated eggs, they can have their own known donor that they know, or they can use one of our clinic donors. The same for using donated sperm. It can be a known donor or a clinic donor. People can use donated embryos, so those would be embryos that remain after a person or couple have finished their own IVF treatment, and in many cases they might have had one or two children from that treatment and no longer don't want to grow their family any further, so are comfortable to donate embryos. Donors or in donated embryo situations, people do have to meet and the donors have to be known to the recipients. And then surrogacy, we have two forms of surrogacy: traditional surrogacy, which is where the person or woman who's going to be the surrogate also uses her own eggs, and more commonly for a fertility clinic, what we call IVF surrogacy, or it's sometimes given different names, but surrogacy where IVF is used, and often in that case the eggs will come from the intending mother, the person who's going to be the mother, or there could be a separate egg donor, or occasionally it could be the surrogate with IVF involved, and we'll talk more about surrogacy as we go on. So talking a little bit more about donated, treatment with donated eggs. That means that the egg donor has to go through an IVF cycle for the eggs to be collected, and that involves, in simple terms, stimulating her ovaries with FSH hormone, and that involves an injection of that hormone. It's not something that can be taken in tablet form, it's in an injection form, given a little injection under the skin, just like if you were diabetic and had to give insulin. And those daily injections are for usually around 2 weeks. And then the egg donor has to undergo the egg collection procedure. The eggs are then put together or fertilised with sperm from the recipient man, or potentially a sperm donor, and eggs can also be frozen into our donor egg bank. So for some egg donors, particularly those that are a little younger and perhaps have plenty of eggs, we might choose to freeze the eggs, if the donor's happy, into our donor egg bank, and then that donation could be split into 2 or even 3 and help 2 or 3 different people or couples. So just a little bit more information about IVF, because if someone's going to be an egg donor, that's a fairly big thing for them to undertake. So, as I said, it's daily injections, and it's usually, most of it, the injections are all designed to be given yourself at home. Our nurses teach people how to do this all the time, and usually people manage that very well. What we hope is that the woman, the donor, that her ovaries will respond to the injections, and you can see this is an ultrasound scan picture of an ovary that's pretty well stimulated. Each of those black circles or spaces is a follicle containing an egg, and once the largest, that should contain an egg, and once the largest ones get up to about 18 millimeters or so, then we would plan to go ahead with the egg collection procedure. And this is and if you just even count in that one view, the ovary is obviously a 3-dimensional thing, that's a 2-dimensional view, but you've got about 9 or so follicles there, so that's potentially 9 eggs, but there's probably some more follicles in that ovary as well. So that's a donor who's responded very well to stimulation. This is a diagram of how the egg collection procedure is done. So it's done with vaginal ultrasound scanning. The woman would have an intravenous drip, IV line placed in her hand or arm, and have some sedating medication through that, just like you would for other procedures like having a gastroscopy or colonoscopy or having your wisdom teeth removed. And then we're able on ultrasound to see the ovaries and very carefully place a needle into each follicle, drain the fluid, and the egg is microscopic. You can see in that follicle that the needle's gone into, there's a tiny little egg there. So that fluid goes into test tubes, and one of our embryologists will always be sitting there while we do the procedure, sort of just a couple of feet away from us in the laboratory, looking under the microscope, looking for the eggs as we go, so as we know in real time whether we're finding eggs or not. And then in the laboratory, the embryologists have got to put the eggs and sperm together. On the right is a picture of an egg. The egg is actually the largest cell in the body, 1/10 of a millimetre, and on the left are some sperm. Sperm are tiny, they're much, much smaller than eggs, and they, to work well, they often need to work in large numbers. If we're happy that we've got good sperm, we'll just put a whole lot of sperm with each egg. If there's any issues with the sperm, then we may need to do what we call ICSI, intracytoplasmic sperm injection, where we inject a single sperm into the egg to try and achieve fertilization. And then this is just a picture of the first 5 days of embryo development. So the top left-hand picture is a fertilized egg, and you can see there's two little circles in the middle there, what we call the pronuclei. One has come from the egg and one from the sperm, and that shows, you know, that those findings, that's what the embryologists are looking for the morning after egg collection to see if the egg has fertilized. The next picture along, top middle, is an embryo that's split into 2 cells, and then the one further along from that is 4 cells, so that would be 1 day after egg collection, then 2 days after egg collection. The bottom left-hand picture is 3 days after egg collection, an embryo that would normally have 6 to 8 cells by that point, and then 4 days after egg collection is the bottom middle, and that's not a good time to look at embryos. They're changing a lot, and you sort of see, you know, you can't really tell how many cells there are. And then hopefully by 5 days after egg collection, bottom right, we have 1 or more blastocysts. So a blastocyst is an embryo that's got 60 to 100 cells, and you can see at the top that sort of bigger blobby bit coming down into the middle is what we call the inner cell mass. If that embryo becomes a pregnancy, that inner cell mass part is the part that would form the fetus and the baby, and the outer part around the whole outside of the circle is called the trophectoderm, and that's what would become the placenta and membranes. So donor sperm treatment, all of our donor sperm is frozen and quarantined before use, so the sperm donor will have screening for infectious conditions initially, and then again 3 months after any samples have been frozen, so that there's really no chance of passing on any infection with the use of donor sperm. And the donor sperm can be used in 2 ways, for either more straightforward donor insemination cycles, which we'll talk about, or IVF treatment. So the woman who's going to become pregnant can undergo an IVF cycle, and donor sperm can be used to fertilise the eggs. But for a number of people, they might rather and also be able to undertake simpler donor insemination treatment. It's all what we call IUI, intrauterine insemination, and that means that in the middle of the cycle, when the woman is releasing an egg, some of the donor sperm would be thawed out, washed and prepared, so we just end up with a small amount of fluid with the moving sperm, and then that's injected up through the cervix into the uterus. And as I said, it's timed for the day that the egg is being released, and we look for that by blood test or often twice daily urine testing. We're looking for the luteinizing hormone rise that happens in the middle of the cycle just before ovulation. That's what a lot of ovulation kits are testing for. And then it's the semen sample having been prepared. And in the laboratory, really, they're getting the sperm to swim up through a gradient, just so that they end up with just the moving sperm. And you can see here, the sperm are injected up through the cervix into the uterus, and we want at least 1 million moving sperm per mil of fluid. So there's a lot of sperm concentrated into a small amount of fluid, and then hopefully some of them will swim up through the uterus and along the fallopian tubes and end up, hopefully one will end up fertilizing the egg that's just been released. So the chance of pregnancy with donor insemination treatment is related to how old the woman is who's having the treatment. And it's the same chance as if you had a heterosexual couple who hadn't tried for pregnancy, who were just setting out to try to get pregnant. It's that same chance. And you can see that obviously as a woman gets older and her eggs get older, the chances get lower. And this is a chance per month. So, if we've got younger women around age 30, we're talking a 20 to, potentially 25% chance of pregnancy per month, so per donor insemination cycle. But if we take a 35-year-old woman, we're probably down to about a 16% chance per treatment. And if we, take a 40-year-old woman, we may be talking about only a 6% chance, and it drops away even further after that. And that's all to do with the age of the eggs. As the eggs get older, they don't necessarily behave and end up with the right number of chromosomes, the right amount of genetic material when they're finally used. So I'm just briefly going to talk a little bit about donor embryo treatment because I'm coming back to how to become an egg and sperm donor, but I'm not going to say too much more about donor embryo treatment than what is on this slide. So as I said, a person or couple who've finished their IVF treatment and have remaining frozen embryos may choose to donate these. We would, if people do, then we would see them, talk to them from a medical point of view, update any medical information, particularly, update their health information, the information about the health of any children that they've had, and their, wider family medical history, because that's all important for the people who are going to, try and use these embryos to have a baby. We also do something called expanded genetic carrier screening for those embryo donors, and I'll talk a little bit more about that when I talk about becoming an egg or sperm donor. We would also, the people who are going to receive those embryos would also need an updated medical report, particularly if they've been waiting for some time and haven't seen their doctor at the clinic for a while. And then there's individual counselling sessions for both parties, and then at least one joint counselling session where they all sit down together and talk about a number of issues. And this is all required for the ECART Ethics Committee for Assisted Reproductive Technology application. So there has to be an ECART application for this treatment to go ahead. It can't go ahead until we have permission from the Ethics Committee. So becoming a donor, I'm going to talk a little bit about becoming an egg donor and a sperm donor for people that might be interested in that. So for an egg donor, we want the woman to be under age 38 years. They simply need to get in touch with us at Fertility Associates. There's a section on the website where you can register to be a donor, and then one of our donor coordinators will be in touch and arrange initial blood testing, particularly, that's looking at a number of things, even just checking your basic blood count, but also particularly checking for infection and sexually transmitted infection. And also for the egg donor, we would do a hormone level called AMH, anti-Müllerian hormone, and I'll talk about that further in a minute, but we want that to be greater than or equal to 5 picomoles per litre. The women where it's lower have a lower number of eggs remaining, and we prefer not for them not to be an egg donor because we're simply not going to get as many eggs from their ovaries. The next step is normally to come and have a medical appointment with one of our doctors, and that will be looking carefully at their medical and their family medical history, but also they will include a physical examination and an ultrasound examination of the pelvis. They will have a counselling appointment, to talk about the law and what it means and all sorts of things around donating eggs, so that they're very clear about what it means for now and for the future. And if it's a known situation where the donor knows the recipients, then there has to be a joint counselling appointment with all parties together. And this process of the donor being assessed and having these appointments is likely to take 2 to 3 months by the time they've done those things. And only after that has occurred and they've been approved to go ahead as a donor do they go ahead and do the IVF cycle and have the eggs collected. Once eggs or embryos, the fertilised eggs, have been, once the eggs have been collected, usually they're fertilised and we end up with embryos, fertilised eggs. Those are frozen and quarantined for 3 months, and then the egg donor is retested for all infectious conditions before those embryos are released for use. So that obviously adds a little bit more time on at the other end as well. So, we've mentioned before with pregnancy rates, but, part of the reason the main reason that we require egg donors to be under 38 is that you can see with that purple line exactly the same idea as the graph I showed previously. The chance of pregnancy per month for somebody drops as they get older, and choosing any age limit is arbitrary, but particularly by the time someone's 39, 40 or into their early 40s, it's getting down to a very low chance per month. So any eggs collected from someone that age are going to have a very low chance of pregnancy. And in combination with that, the risk of miscarriage goes up. So the dotted red line shows the chance of miscarriage if somebody does become pregnant at a certain age. And it's all for the same reason, that the eggs are older. When they're finally called up to be used, they often get the wrong number of chromosomes, and therefore pregnancy either doesn't happen, or if it does happen, it's much more likely to miscarry and not continue. And then this is a graph looking at AMH, the hormone level I talked about. So anti-Müllerian hormone, it's a hormone produced by some of the little eggs at a certain stage of development in the ovaries. And for most people, that hormone level gives us a pretty good idea about the number of eggs remaining. And we think of it in terms of, whether it's normal for age, below average, above average. And so this graph, you can see the solid black line is the 50th centile, so roughly average numbers for age, and we expect that the number of eggs is going to go down as people get older. The dotted line above that is, or the dashed line above that is the 75th centile. Anyone who's got an AMH level above average, it's reassuring that they've got a good number of eggs for age. And then the dashed line below the solid black line is the 25th centile. So even being above that line is pretty reasonable, because you're not in the bottom quarter for age. If you're below that line, you're getting into the bottom quarter for age. And if you're below that finely on, or below that finely dotted line, the lowest line, that's the 10th centile. So if people are below that, they're in the bottom 10% for age. So, they're getting down to pretty low numbers for age. The colours, the green, the yellow or orange, and the red are for indicators for IVF treatment that give us an idea as to how many eggs we might collect. So if people are in the green zone, then 80% of the time we're likely to get at least 6 eggs on an IVF cycle. If people are in the red zone, then 80% of the time we're likely to get less than 6 eggs, so a much lower number. And the people in the middle, in the orange or yellow zone, 50-50. Some of the time we might get a better response, and some of the time less eggs. But it's very good for adjusting, patients' and doctors' expectations about egg number. And you can see that, the people that are in the red, we ideally don't want to be an egg donor, because we pretty much know we're going to get a very low number of eggs from them. So becoming a sperm donor, the age limit for a sperm donor, clinic sperm donor that we use, is age 45. It's not uncommon to have recipients wanting to use a known donor who's older than 45, and we will, 45 to 55, we're not quite so worried about, but we would have a conversation with them about some of the increased risks from using sperm from older men. And over 55, we'd prefer that they didn't use a donor that was over 55, because there are increased risks for children when the sperm comes from an older man. And also there's issues about whether the child might get to know the donor for very long. When the child's 20, the donor could be 75, 80. So there are other considerations. So again, the sperm donors just need to contact us and register on the website. The donor coordinators would be in touch and arrange their initial blood tests, and again, it's particularly looking for any sexually transmitted infections, hepatitis, HIV, all of those things. They come and have a doctor's appointment, and that will normally include a physical examination as well. They will have a counselling appointment just like an egg donor would, and if they're known to the recipients, then there needs to be a joint counselling session. And again, doing those things is likely to take 2 to 3 months. They can then go ahead and bank some semen samples, and those samples are all quarantined for 3 months. The donor's retested for infectious conditions before the sperm is released for use. So in practice, it means that if somebody has someone that they're wanting to have as a known sperm donor, it's probably going to be 6 months until there's actually sperm available for use. So something that a lot of people would be interested in is how many times can a donor donate. So we have our current policy is 7 families per donor. For clinic sperm donors, historically it was 5 families. There's now a 7-family limit. There is actually, the New Zealand fertility standards do say it could be as high as 10 families, but I don't think any of the clinics are going as high as that. Clinic egg donors, it's unusual, because they have to go through an IVF cycle, which is quite involved. It's unusual to have an egg donor go through that more than 1 or 2 times, occasionally 3, and it's quite unusual to have them go through it the maximum number of times and get to the maximum number of families. So it's more likely they would only do it once or twice. So for people who are, recipients of donated eggs or sperm, if they're not already, often these people will already have seen us and not know until after they've seen us, or perhaps done unsuccessful treatment and perhaps got older, that a donor is really what they need. But if they hadn't previously been in contact, we would want them to register and come and have a doctor's appointment. Some of the things that we need to cover are, in that, as well as medical information, understanding how the donor program works, what the law says, the difference between having a clinic recruited donor and a known donor. We would then add their names to our donor waitlist for eggs or sperm or embryos, unless they've already have a plan to use a known donor. And then once a donor is available, we would normally see them for a further medical review appointment to actually plan the treatment. And sometimes they may have waited quite a while, so there may be medical information to update. And also, it's, if they've selected the donor's been selected by that point, it's a good opportunity to look at the medical information and test information from the donor, and there may be things to discuss with the recipient. Every donor, so our clinic donors, there will, even even when it's a known donor, they make a profile. So every donor makes a profile of information, and that will include information about what they look like, ethnic background, age, whether they've got any children, interests, education. Usually the doctor's medical letter is in there, just a whole lot of information so that recipients can make a choice. And once those things have happened, then the recipients can proceed with treatment. If it's egg donation, often that's the point at which the egg donor goes ahead with the cycle. If it's sperm donation, then the sperm donor's already banked the sperm, and the recipients can go ahead with treatment. So donor waiting times, that's been a big issue for a long time, and it has changed on and off over time, but we generally have had reasonable weights to use both eggs and sperm. It depends on how many donors have been recruited, and we always need more donors. Currently, for egg donors, we're probably sitting at around 2 years, which is, for a clinic recruited egg donor, which is a long time. For sperm donors, for simpler insemination treatment, we're probably around 3 years, which is where the donor sperm waitlist has been for a while. But we have had a situation for the last 6 to 12 months where there is sperm available for IVF a lot faster than that, maybe only around a 6-month wait. And that's because there's perhaps donors where we've got less sperm remaining, or their semen samples just don't freeze and thaw as well, and they're only suitable for IVF treatment. There's a number of reasons, but at the moment we have that, quite big discrepancy. For many people, finding their own known donor will, may be the fastest option. So expanded genetic carrier screening, this is part of the assessment for all of our donors, and over time, as the years have gone by, we've gradually screened for more and more gene mutations. So all of us have some gene mutations. And the testing we've been using for the last couple of years screens for about 550 gene mutations, which is obviously a really big number. And if you screen any of us for 550 gene mutations, 70 to 80% of us will have at least one. So we would always inform the donors of these. These are usually for what we call recessive conditions, which means that you having the gene mutation yourself is not going to cause any problem. It's just if you go to have a baby with a partner, or you're a donor and you're a sperm donor, and where the person that the eggs are coming from, if that person has a matching gene mutation, then there's a 1 in 4 chance of a child having whatever the condition that results from having 2 of those mutated genes. So we inform donors. They may need to know, if they haven't had their own children yet, they would be sensible to look at getting a partner tested in the future. And if it's one of the more common gene mutations, they may want to talk to other people in their family as well, because other family members may carry that gene mutation. So quite often what that will mean is that recipients need to do the same testing to make sure they don't carry a matching gene mutation to the donor. If they do, there would then be a 1 in 4 chance of having a child affected with the condition that the mutation tests for. In most of those cases where a donor is involved, we would then advise the recipients to change donor to a different donor. If it was a clinic donor, absolutely, that's what we'd want them to do. If it was a known donor, their sister or brother or somebody close to them, then they might choose to change. They could change donor. They could potentially do IVF and test embryos, but that's making things more complicated and more expensive. The testing for the expanded genetic carrier screening, it's just a cheek swab or saliva sample. The donors do it as part of their workup, but recipients need to pay the cost of that. So this is just showing, the type of conditions that we are looking for with that carrier screening. So the most common are on the left, the autosomal recessive conditions, where if you've got, a male and a female having a baby, regardless of whether they're donors or what the situation is, if both of them carry a matching gene mutation, then the bottom row shows what are the possibilities that could happen. You could have a baby that doesn't inherit either bad copy of the gene. You could have, that's 1 in 4 times, 1 in 2 times, so half the time a baby will inherit one of the bad copies of the gene from one of the genetic parents, and 1 in 4 times they will just inherit a bad mutated gene from both genetic parents, and that's when they were affected with the condition. So cystic fibrosis, spinal muscular atrophy, there's a massive list of recessive conditions, some of which are incredibly rare. The other kind of inheritance that's mentioned there is X-linked inheritance. That's slightly more complicated. It's where the mother or egg donor carries an X-linked condition, which on the X chromosome, and because a male has 1 X and 1 Y, that one abnormal gene can affect a male. If the baby is a male and gets the bad copy of the gene from the mother, he would be affected with the condition. But 1 in 4 times you can get an unaffected male because the male gets the good copy, the good copy of the X chromosome that doesn't have that gene on it. And the same for getting an unaffected female, but you can also get a carrier female. So the carrier female, because they've got 2 X chromosomes, is usually like the mother and fine with the, doesn't necessarily have a problem, although sometimes they'll have a milder form of the condition. But the carrier screening is mainly for recessive conditions, but there are 1 or 2 X-linked conditions in there as well. So I'm going to move now on to surrogacy. So with surrogacy, we talk about a surrogate and the intending parent. So the surrogate is the person or the woman who's going to carry the pregnancy and give birth to the baby, and then the intending parents are the people who, who the arrangement is for, who are going to be the parents, but for some reason require a surrogate. And there may also be an egg and or sperm donor involved in that arrangement as well. So anyone who's looking to be a surrogate, they need a similar workup to a donor, with initial blood screening tests and tests for sexually transmitted infection, and then a doctor's appointment and counselling appointment. And a lot of that is very much looking at, their past medical, mental health, and, psychosocial history to see whether there's any concerns, and whether they're suitable to proceed as a surrogate. There's then, joint counselling with the intending parents. The intending parents will have also had, a doctor's appointment and individual counselling. There has to be legal reports, so lawyers, 2 lots of lawyers, one for each party. And they need a legal report or advice. And the reason for that is that the woman currently, with our current legislation, it's adoption law, and the woman who is pregnant, who then gives birth, is seen legally as the mother because she gave birth to the baby, and the law's old and it doesn't recognise anything that you might be able to give birth to a baby that isn't genetically yours. Her partner at the time would be seen, would be recorded as the other parent on the birth certificate, and the intending parents then have to adopt the baby, which can be, which is a process that can take at least 6 months. And, obviously people may be, worried about whether it's all going to happen. They have to be assessed by a rangatamariki as part of that ethics committee application as well. Some of you may know that at the moment surrogacy law reform is going through Parliament and hopefully will happen, but any law change is slow, and even if it does happen in the form that it's proposed, it will make things a little bit simpler, but there will still need to be legal advice because there will still be a legal agreement and some sort of parenting order that the surrogate would need to sign, if they're happy to sign that and hand the baby over legally within a few days of birth, then presumably the original, the birth certificate would be issued with the actual intending parents listed as the parents, which would be, quite, a nice improvement on the process. But it won't happen without legal involvement. So all of these reports have to go in to the ethics committee, and then it's only with approval from the ethics committee that we at a clinic can actually go ahead and treat these people and place an embryo into the uterus of a surrogate. Often we don't do the IVF treatment for the intending parents until then either, although sometimes they may have already done IVF treatment in the past. So for the intending parents, as I said, they also need a medical appointment and workup, and there needs to be a really good medical reason to do surrogacy. If somebody, is just too busy or doesn't want to be pregnant, that wouldn't get far with the ethics committee. There really needs to be a good reason why the intending mother can't be pregnant. Individual and joint counselling, same thing, lawyers' advice. They have to have a rangatamariki approval for adoption, and that all goes in with the ethics committee application, along with all the details about the surrogate. And then, once that ethics committee approval is through, if it is approved, then we can create embryos, and the surrogate can have embryo transfer and hopefully become pregnant. So ECART is the Ethics Committee for Assisted Reproductive Technology, and that was set up with this Heart Act and order that came in 2004. And in general terms, the cases that have to go to the Ethics Committee and can only go ahead when there's approval are surrogacy cases, embryo donation cases, and donation of gametes, so eggs or sperm, between certain family members as well. So usually it's cases where perhaps it's a niece donating eggs to an aunt, so between generations in a family, And, you know, there are some situations too where if it's a sister-in-law or a brother-in-law donating eggs or sperm, that it would have to go to the ethics committee. You know, we obviously check on that when we first see people and find out who their donor is going to be and whether there's any sort of family relationship like that. The Ethics Committee is a government-appointed committee, and it has a range of members, but it has to have at least one fertility specialist, so someone actually working in this area. So one of my Wellington colleagues is on, and another Auckland colleague are on the ECART at the moment. There's an ethicist, there's at least one lawyer, there's a representative from the Ministry of Children to try and represent the views of children. There's at least one layperson, there's a Maori representative, I think there's a Pacific, someone of Pacific origin on the committee now as well. So, you know, there have to be certain, I may have missed some of it. There needs to be a scientist as well. So, you know, there's certain categories of membership. The cases are presented as anonymously as possible, so no patient names are used. People in the applications, people are referred to as S for surrogate and IP for intending parents. And the Ethics Committee meets around 6 times per year. And, you know, all applications have to be in, everything has to be in about a month beforehand so that there's time for that information to then be circulated around the committee members so that they've looked at it and can have a good discussion and consider it at their meeting. So, you know, having a case go to the Ethics Committee takes time. It's not something that can happen really fast. So I think the final bit we're going to talk about is costs and funding. Public funded fertility treatment is available in New Zealand, but it is limited and it's not available to everybody. So people have to reach a high enough what's called CPAC, Clinical Priority Access Criteria score. And that's the same kind of scoring that's used for public funded surgery. And they get points in that scoring system for what we'd call biological infertility. So having, you know, the woman having significant endometriosis, blocked or damaged fallopian tubes, you know, the man having a very low sperm count, things like that give a high point score and would mean that a person or couple may well qualify for public funded treatment. But, you know, a lot of, you know, same-sex couples will most of the time not qualify for government-funded treatment. Single women usually won't qualify. So there's a lot of groups of people that don't qualify for public, you know, don't get a high enough score to get public-funded treatment. And, you know, the woman has to be under 40, body mass index 32 or less when they're scored, also a non-smoker or non-vapor for at least 3 months. So they're all things that are in there as well as not having more than one child at home. So they're all, you know, all things that very much limit who actually gets public funded treatment. So the other, and just to give some idea about costs, any cases that require ethics committee approval, even if the actual treatment is public funded, the process of ethics committee approval isn't covered by public funding. There is no separate funding for the clinics for that. And the current costs for, you know, putting in an application to the ethics committee at the clinic are basically $4,000. You know, it covers all the counselling and all the work that needs to be done, and workup of a surrogate is, you know, before you pay the $4,000 for the application fee is $3,190. Other things that wouldn't be covered for surrogacy are the lawyers' fees. You know, the lawyers are separate; they're not covered. So, you know, there's quite a lot of cost with surrogacy, even if the actual IVF surrogacy treatment is public funded. Treatment with donor sperm. Simpler insemination cycles are about 4,000 per cycle, and IVF using donor sperm, depending on exactly what's required, doses of medication, etc., is going to be about 18 to 22,000. Treatment with donor eggs, you know, including working up egg donors, is between, you know, 21 or closer to 22 and 25,000. So, you know, donor treatment is definitely expensive. So that is the end of my talk. So thank you for listening. I'm, very happy. We're all very happy to at any clinic to take inquiries and answer questions. On the website, the other thing people can do that can be handy is a free nurse consult. So that's usually a 15-minute appointment that's scheduled in with a nurse. And, if people aren't sure what to do to start with, or whether they should be seeking treatment, sometimes that's a good starting point, just to have a chat with one of the nurses and get pointed in the right direction. So we do have some questions here. I'm just trying to work out how to see the top one. I don't know if I can. Just give me a second, because I can see it now. So someone has asked if they've had their uterus taken out but still have their cervix, how would we get the eggs out? So some of the surrogacy cases that we do, the woman would have been born without a uterus, and that would include no cervix, or the woman might have had to have a hysterectomy and have the uterus removed for a cancer or a massive postpartum hemorrhage. There could be a number of reasons. So we don't need the uterus to do IVF and collect eggs. So the ovaries almost always will be visible with vaginal ultrasound, and when it's just a needle through the vaginal wall into the ovary, and whether or not the uterus and or the cervix are there doesn't make any difference to that. Someone else has asked, can a woman over 40 be a surrogate? And, will they carry a healthy, I think they mean healthy baby? The answer to that is yes. There's no set upper age limit for surrogacy, but what we know is that the older a woman is when they're pregnant, that there are greater risks in pregnancy, and we're particularly worried about women over 45. So I would think, that's a fairly good guideline as a cutoff around 45 years. It would be, I think, there'd be no certainty that the ethics committee would approve a surrogate older than that. We would certainly be medically worried about their risks. The baby, yes, if someone is 44 or 45, their risks of conditions like diabetes in pregnancy, high blood pressure, preeclampsia might be, going to be a bit higher because of age. But if they've previously had straightforward pregnancies, then hopefully any of those risks can be managed. The actual sort of genetic health of the baby is about the age and health of the woman that the who would often be the intending mother that the eggs have come from. So things like risk of Down syndrome is related to the age that of the woman that the eggs came from, not the age of the surrogate, if she's not using her own eggs. And if she was 45, the chance of getting pregnant using her own eggs would be tiny. So someone's also asked, why would an ethics committee e-card application be denied? Well, lots of reasons. We try hard at a clinic level to, if we have an application where we can see that there's going to be problems, where maybe somebody's found someone to be a surrogate who, clearly has a lot of risk factors, perhaps has had quite complicated pregnancies before, maybe is a single mother with several children and very little social support, maybe has a complicated mental health history, we'd be very much advising those intending parents and the surrogate that we didn't think this was a good idea, and hopefully they wouldn't continue. But if they did and it went to the ethics committee, we'd be quite concerned that they may decline it. So, the ethics committee has a guideline to follow, but they're particularly focused on the health and well-being of any children, so any baby that's born, of the intending parents and of the surrogate, so they're all equally important. And, if they think that it's too risky for the surrogate, that there's too much risk, then they will, they have every right, and they do deny, they do refuse to grant permission, and then we cannot go ahead at a clinic level if there isn't approval given. And then someone's asked, if they're 41, would it be better to use an egg donor to get a healthy baby? I mean, yes, in many ways. Using younger eggs is going to give a higher chance of pregnancy and lower risk of chromosomal abnormality. But on the other hand, a number of 41-year-olds will still become pregnant, either naturally or with IVF treatment. So, when we're talking to people, it depends what's happened to them so far. It depends how many eggs they've got remaining. It depends what they want. But, using an egg donor is generally people's second choice, not their first choice. They'd usually rather use their own eggs. But, if things aren't looking good for them and their chances of pregnancy are very low, then using an egg donor could be a good second choice. Someone's asked, how often do intending parents need to change donors, because of the genetic screening? I'd say very uncommonly. I don't think I've come across that yet, but, if we, the more treatment we do, there will be times where, someone wants to use an egg donor or a sperm donor, and they, have a matching gene mutation, and then would be best to change donor. But it's quite would be quite infrequent. Someone else has asked about what sort of mental health conditions wouldn't be suitable for someone to be a surrogate. Previous postnatal depression, but well supported. I mean, as we all know, particularly depression and anxiety are really common, and there's many people who will have had, an episode and been treated and be otherwise well. So absolutely, we will have, people applying to be a surrogate who have had some mental health issues, but, if it's more severe, if it's happened numerous times, if it's resulted in hospitalisation, all of those things are going to make it more significant. But, we'd quite often have someone who's had a bit of, postnatal depression after having one of their babies, but if it was recognised and managed and there's a good plan in place for them to be supported, then, and other factors are okay, then they may well be approved as a surrogate. But they are things that the ethics committee is understandably concerned about. Someone's also asked, can they not get funded treatment for surrogacy if they're aged over 40? No, they won't be able to. And then someone said, how common is surrogacy, both heterosexual and same-sex couples? I mean, at a clinic level, it feels like surrogacy is fairly common, but really the number of cases at the ethics committee each year is in the range of, I think, 30, 40, less than 50. So really, compared to the number of pregnancies and babies born each year in New Zealand, it's a very small number of, cases. But at a fertility clinic, there are important cases that, involve a number of different people, and, so it feels like it's more common than that. And there will absolutely be a mixture of, people doing surrogacy and reasons for that. So there'll always be a number of heterosexual couples where the woman was born without a uterus, or has had to have a hysterectomy, or maybe has really serious medical conditions that mean that it's not safe for her to be pregnant. That'd be some of the most common reasons. We're increasingly seeing more same-sex male couples, probably less likely to have same-sex female couples doing surrogacy, because hopefully one of the two of them could carry a pregnancy. So yeah, a whole range. And then final question, someone said, in a same-sex female relationship, if you get your own known sperm donor, does this reduce the wait time of 3 years? Absolutely, it does. So the known sperm donor needs to be worked up, and that might take 6 months until the sperm available for treatment. But that's a lot shorter than, once that sperm is banked and out of quarantine, they can go ahead with treatment and not need to wait 3 years on the waiting list. So, we very much would encourage people to try and find a donor if they can. Okay, well, that is the end of the questions and the end of the session. Thank you very much, everyone, for listening. And just please, remember that your local Fertility Associates clinic is always happy to have a chat and, answer the odd question and point you in the right direction. Thank you, and good night.